Hello, good night. This is Ramón Medel, and tonight we are going to speak about Blefarofimosis syndrome. Hello, good night. This is and one of the we are really new in this technology, and I want to say that this is not our comfort zone, and I ask you for your sorry if the technology is not working properly, but we try to do our best. So about Blefarofimosis, one of the this is a syndrome that is very common, but there is no good studies in order to know exactly the number of patients around the world. But there are some information that we want to give you tonight. First, we are going to give a little speech about general terms in Blefarofimosis, and then we are going to ask you for the questions. And I want to thank you for all the questions you share with us. We have a lot, and please feel free to contact us and to write down all your questions, and we try to do our best to answer all the questions tonight. So very important things about BPES, Blefarofimosis syndrome. First are the dates, some important dates in order to know exactly where we are. So the first reference in the world, that the first person that say a word about Blefarofimosis syndrome, this syndrome, was about 1841, and was von Neumann. But the first one that described the syndrome, or a syndrome like we know now, it was in 1889, Vignes. One of the most important advantages, or one of the most important advances in BPES was related to an autosomical dominant inheritance, and it was Dimitri in 1910, so at the beginning of the last century. But remember, this is a syndrome that probably 100%. Half of the patients are sporadic, and the other, and then when it starts, it has an autosomal dominant heritage. In 1976, another important feature was the relation in between BPES and infertility, and was about a study written down by Moraine. And this is very important, as we will see in some patients with BPES. And the last reference that I want to remark is the one from Crisponi, that was the one in 2001 that rated the alteration of the chromosome FOXL2, and this is a problem in the chromosome 3 in the locus 23 of the arm Q. So what's Blefarofimosis now? What's BPES? What's the meaning of BPES? The B is for Blefarofimosis. What's Blefarofimosis? I know all of you, all of the families involved in BPES, you know a lot of BPES because you read so much about that, and that's quite a simple thing for any person that in the audience, if they don't know the general terms, and I think it's important to remark. B is about Blefarofimosis. What's Blefarofimosis? What's the meaning of phimosis? Phimosis means that the eyelid is short horizontally. Okay, shorter than normal, and this is phimosis. The E is about epicanthus inversus and telecanthus. Not only epicanthus, and telecanthus. Epicanthus is a fold in the medial aspect of the eyelids, and there are three general types of epicanthus, 3 or 4. But the one that we find in Oriental people is the tarsal, the tarsalis epicanthus. Is from the upper eyelid to the medial canthus. There we have the palpebralis, which is the upper to the lower, and the epicanthus inversus, which is typically involved in the BPES, is from the lower eyelid to the inner canthus. And this is the we can find all types of epicanthus in a lot of syndromes, but epicanthus inversus is really typical of BPES. But more important for me than epicanthus, what is we have to take rid of it sometimes, is telecanthus. What is the meaning of telecanthus? Telecanthus is the distance in between the palpebral fissures, bigger than normal. So the eyelids are one from another more away than normal, one of each other. This is telecanthus. Ptosis, you know that the ptosis in BPES is a severe ptosis with a really bad levator function, and we have to solve it with a Frontalis procedure. You know that my favorite, and I think the best technique for this is the Frontalis flap technique, and we have a very nice results in those kids. And the S is only from the syndrome, and this is general terms of BPES. But one of the good news about BPES is that orbital bones are perfect, and the globes themselves are in good position. So the interpupillary distance is normal. So everything is normal but the eyelids, and we have to try to understand what is going on there. Another thing in this syndrome is the face of these children is a syndromic face, and sometimes a mongoloid is confused by a mongoloid syndrome and like Down syndrome, and it's no way. So there's a few cases of mental retardation, but the normal feature is very clever persons, very clever kids with a very high intellectual coefficients, higher than median. So they're clever than the median. In BPES, we have two types. Type 1 is related to POF, premature ovarian failure. So, and what it happens is about the contiguous gene. So the gene that is altered in chromosome 3 from BPES is the next to the one that is controlling the ovarian maturation. So if we have this alteration, you will have premature ovarian failure. And the type 2, the more common, which is related to normal fertility. And this is important because if we have a girl with a premature ovarian failure, the only way to know it is to test the hormones when they are adolescents. And but it is nothing to do with that, unfortunately, because these are they are not making ovules, and they are infertile. This type 1 is related to, is transmitted by men, and when it happens to the woman, it has infertility. What are our other periodical findings? For example, lacrimal, canalicular, and punctant are almost always abnormal, and abnormal in position and sometimes in the function too. prominent brows, S-shaped brows, but nothing. Those are nothing, not important. But one that we find very common is the shortage of the eyelid of the skin. So the skin of the eyelid. So the eyelid itself is quite short, and it makes it difficult to have a good reconstruction sometimes. And sometimes we find hypoplasia of caruncula, little findings that are not important in symptoms or the life of the kids with BPS. But one of the things that are really important are the things related to the lacrimal gland. And some studies remarks that half of the patients, if we do a CT scan, we can't find the lacrimal gland. So it has no lacrimal glands and has a lack of lacrimation or a reduced lacrimation, importantly, and this feature is almost always bilateral. And this is in 52%, but in 33% we have less volume of those glands, and this is not related with the formation of the lacrima, but these are reduced. We cannot make a relation straight, but these are reduced lacrimal production. Well, this is one of the things that is important to understand are about the proportions on the face. If you see in this BPS child, we have a fissure, Blefarofimosis, a shortage of the fissure. We have a shortage of the other fissure, and we have a long distance in between the fissure, which is the telecanthus. And this is what makes a syndromic face. And this is important because this is one of the things that we want to change, if we want to change, because we will see. If we see in this patient of mine that we did a frontalis flap when she was 1 year old, 1 year after the surgery, and 6 years after the surgery, and you see the proportions of a bilateral congenital ptosis, you see the proportions in between the intercanthal distance and the fissures are more or less the same, are not the same, and we can discuss it if you like, but are proportional. So the distance is more or less one fissure. It's more than one fissure, but it's more or less this, and it goes from, in any age, is proportional. In severe congenital ptosis, not in Blepharophimosis syndrome. And if we see it in adult patients, so like he's not an adult, he's my son, my 60 years old son, and I did a picture of him yesterday, and we see that the fissure are exactly the same. So it's the same amount of eyelid fissure is more or less the same of intercanthal distance than the other distance. And you see, one of the first things that we try to do when we correct the epicanthus, it's not the epicanthus itself, it's more about the telecanthus. The epicanthus, of course, but the telecanthus is very important. And this is one of the image of the patient that we make a epicanthus telecanthus correction before the ptosis surgery, and you see that we can change the proportions of the face, and this changed dramatically the aspect of the children that came from a syndromic face to a non-syndromic or more regular proportions. And this is pre and post epicanthus correction. Yes, I am on the end. So what's my philosophy when I'm facing a patient with a Blefarofimosis syndrome, when I'm thinking on Epicanthal, I always think on leave the less scar possible, because one of the things I hate is when we leave marks, and I don't want to leave any mark in any patient, not in this patient, neither in the ptosis patient. I want to hide the incisions. I want to avoid those visible incisions here. But when I operate orbital tumors, I do the same. I can remove a big tumor through an incision that is not visible, and that's my aim. I don't want to leave marks on my patients. And in Epicanthus, the techniques that we use to do are really scary techniques, and we have some visible scars here that I don't like, and we try to improve the technique in order to avoid those scars. And in Epicanthus, for us is first surgery if there is a severe Epicanthus telecanthus, and we have to fix it before doing the ptosis procedure. So we have to fix it horizontally, and then we fix it vertically with the ptosis correction. And when I think in ptosis, sometimes we do as first step ptosis. When we think the ptosis gets a little bit of amblyopia and lazy eye in Blefarofimosis syndrome. But I have to tell you that Blefarofimosis syndrome is a poor amblyopigenic syndrome. So it's more uncommon to have lazy eye in Blefarofimosis syndrome because it's bilateral and it's symmetrical. So both eyes has the same evolution and the same development. So it's less common to have amblyopia. But if we are thinking, or we see that there is one best than the other, and is doing a little lazy eye, we have to fix the ptosis before, in order to stimulate this eye and avoid the lazy eye. Again, in ptosis less scar, but frontalis flap is less scar. It's invisible because it's hide on the skin crease. Less complications. Frontalis flap is best because we avoid problems with the materials, with the incisions, and we avoid complications. And it's more durable. And frontalis flap in my hands, and I think is the most durable technique in congenital ptosis. So what to do with a Blefarofimosis syndrome? One of the things that we can do is don't do anything. They are handsome boys, they are pretty girls, they are very clever persons, they are beautiful. So we don't need to do anything on them, and this is a possibility. But if we want to do to improve the condition, we can do first Epicanthus, we can do first ptosis, or we can do both together, and we can discuss this tonight if you like. This is one of the things that is more important to understand why we do ptosis first or ptosis only, because vision is affected or something like that. Like this lady here, that we did only the ptosis correction when she was some months of life, and this is evolution. And if you see, this is a very nice evolution, and we didn't take care of the Epicanthus. We can do it, but the main problem on her probably was the vision, and we did the ptosis only, and the result was very good. And we have time to do the Epicanthus. We have time several times, and we have the whole life to improve it. But she's happy. I'm sure she's happy, and the parents too. And another case, that this is the case I show you in the first image. So we can do it together if we like. Is a better indication. We can discuss this, but this is a lady that we did the Epicanthus and the ptosis together. We improve the syndromic phase, and we improve the ptosic at just one stage, and it can be done. And I think that's it. So I ask you to write down if you have questions or doubts or whatever you like. I think we will have some time to see to ask some questions. And thank you for your attention. So this is my website. Ramón Medel. There is all information, and I think that if you subscribe yourself to the YouTube channel, you have all the videos that we will set in the future. And let's go with the questions. Hi, Dr. Medel. Can you tell me the recovery process of Epicanthal surgery? So the Epicanthus, there are several techniques, and I'm doing one that is the minimal incision, which is a line, and through this line we can work and do everything that we want to do, and we are modifying the technique. We modifying some steps, and we are going to polish it. But the post-operative care is really easy. So it's just to use ointments in order to make heal the wound, and without any infection, because we set some stitches there that usually they are really absorbable. We don't need to remove, and you have to put the cream here, avoid the glasses, and to take some oral antibiotic, and this is all about avoiding infections. And this is very simple. The thing is that we are tightening horizontally very much the eyelid, and we don't need any other pressure sometimes. And when we tighten too much, the eyelid at the beginning is the aperture is shorter, but in the next days, weeks, they start open as before. But this is the first step, in order to do the second, which is the dosage correction. Okay. Soso Kelly asks, with a virtual consultation, are you able to determine if our daughter's vision is affected, and when would it best to do the surgery? So no. So you have to test the vision in your place, and with any ophthalmologist, and this is very. I'm sure any one of you have your own pediatric ophthalmologist, and they take care of the vision, because this is mandatory. This is very important in order to know if is there some is there the lazy eye or not, if the both eyes are watching the same, and this is very important, because this make us the decision to do the surgery of the doses before, or we have time to correct it. If we are thinking on that we have lazy eye, we have to do it as soon as possible, and you have to take your visual test in your place. If you came to our center, or we can test it there, and but not with the video conference, for sure. And what is the best surgery? I will advise you what's my opinion about what to do first, or do it together, or if you need to do something, in my opinion. And for sure, in a video conference is perfect. This is all the media are really really good for that. So we have to take profit of it. So let's see. So there are some questions here from the group. Mona Ben Hassin, why doctors in Europe are not accepting the flap front surgery, even though that it is the best method without the scars and beneficial? I don't know. This question is not to me. This question is for all the rest of the doctors because it's the best technique. So the thing is, what is difficult for any doctor, and you have to understand, so that the doctors, we have a training time, and when we are really experts and we have experience, and another technique came to us, we have to start little by little in order to have good results. The problem with this technique, with this ptosis patients, frontalis flap, is that the indication is hardly ever, in almost always, in on kids, and it's very difficult to improve your technique in kids. So I never recommend to do the learning curve on kids. So is that why they will keep some years in order to have result? But I'm sure this is technique better than the rest, and I'm sure the slings are a little bit better in the future. Another question. This Joe Breed. Do you have any insight into why most of the plastic surgeon in the United States seems to default to slings? Well, it's the same question. So, this slings are in our possibility. The gold standard is the fascia lata brow suspension, and this is a sling, and this is the most common technique in the last years. But believe me, so this is better, and it's about the learning curve on kids, and it's better than to practice on kids. So little by little, I think all the surgeons will move to the better techniques, but it will take time. Let's see more questions. Isabel Lee, how does the Epicanthal surgery shorten the distance? Also, is there any side effects regarding the tear duct? Very good question, Isabel. Very good question. So, is what I told in my topic, in my talk. So, it's not about the fold, it's about the telecanthus. So we have to improve the fold and make a good appearance there, and the nose to be concave and as a regular person. But it's about shortening, and we have to plicate the tendon. There is a tendon here, which is the problem is there. There's a lack of development of this zone, and the tendon is really lax, and we have to plicate the tendon and fix it in good positions. And you are very sharp on your second questions about the problems or the tear duct, because tear duct, because there is exactly the position where the lacrimal sac is, and we have to be really gentle with the lacrimal sac in order to avoid problems of tearing. Because if we are really rude or we have problems on that zone, we can have blocked the lacrimal sac, and we will have tearing, and this is another problem to solve in those kids, and we have to be really gentle. Is that why it's not a simple surgery? It's a very delicate zone with a very anatomical points, and we have to be really gentle on the management of it in order to avoid problems. Another questions from Soso Kelly 1. Is there a possibility that you will come to North America to do surgery similar that you are doing in Peru? It's very difficult, Soso. I don't know your name, but it's very difficult. Why? Because in Peru I have permissions. I did my test as a as an ophthalmologist, and I can practice there as an ophthalmologist, and I feel safe there, and it's better to be like this. I'm not. I think it's a difficulty about permissions to do surgeries in United States or other countries, and I think but nowadays we are having patients in Barcelona, and in Malaga we will have from abroad. Some people that bring their kids from Asia. Some of you ask about from Australia. Australia is the other part of the world, and so you bring your kid with 1 year old kid, and you bring it to Barcelona or to Spain. We do the surgery, you go back. So I feel very proud of that. But I think Peru is very close to America, to North America, and it's closer, I think. And you have to choose. If you want me, for me, it's very difficult to go for legal problems. Have there been any notable advances in BPES treatment in the past decade or so? Well, I think yes. I guess you are thinking, or is a question about from Joe Breed. Joe, I think you are thinking on advances in surgery, and all that what we are showing is really new. So Frontalis flap is a fantastic advancement in the technique, advancing the techniques, and we have really long-lasting results without visual scars. Without with one surgery we can achieve a long-lasting result, and of course in the Epicanthus telecanthus techniques, the same. We are improving the incisions. When I want to explain you one thing, when I was a fellow in London, I did a work with 100 Blepharophimosis syndrome patients. 100 is a lot there. So they had, because this was a big school on oculoplastics, and Jack Mustarde was the first there, was really involved on Blepharophimosis syndrome, and Richard Collins was my mentor, my professor. They was really involved on ptosis and Blepharophimosis syndrome, and I have the opportunity to see 100 of charts of patients, and about what was the best technique at that time, and our result was that BY incision was better than double setaplasty or other techniques on the Epicanthus. But we are doing different techniques now, and we are doing modifications or those techniques, because the people that we operate, a lot of those patients, we have the opportunity to see better what is improvable, and try to do little changes in order to improve patient by patient. And we are having really a nice result, and on the changes that we are making now. So we are really happy about that. But of course, there are a lot of advances. Okay. Cristina Coco Noya. We are considering travel to Spain, as we are inspired by you, by your result, and we thank you. The procedure to bring eyes closer together. Wondering if there is a difference in those procedures. So yeah, I think I already asked this question. So it's about to fixate, to short the ligament that is really laxed, and to tight horizontally the eyelid. And it doesn't matter if you do a setaplasty, a Mustarde technique, or a BY, or a redraping technique or any incision. It's about to take what you do after, and if you fix the tendon, if you remove the excess of tissue that sometimes is there, and you fixate the medial canthal tendon in position. So this is very important. This is very important about that. Helen Mesfon. We will see you tomorrow. We can't wait. Oh, thank you, Helen. I'll see you tomorrow. More questions. Jolie and Daddy. Nice to see you, Dr. Medel. We are going to see you in Spain in May. Hope you are doing well. Thank you very much. I'm doing very well and hope to see you soon. So I'm really impressed about. I'm honored I'm proud to have your kids from abroad. So one of the things that in medicine are changing is about humility, and I'm very happy to help anyone, but as I'm a father, I'm thinking if my son and my daughter they never get into any operation, but if they had to, so I will think very well who is the doctor in charge of it, because it's very important. It's much more important than me, and if I had this responsibility from you, I'm really honored, and I'm always this is a big pressure on me, because I want to do best, because I'm a father, and I want to do the maximal achievement in the minimal opportunities, in the less number of operations, in order to don't let suffer the kids and don't let suffer the parents. That the parents suffer a lot, and some of you are, and you suffer a lot, and you feel guilty because you think you did something wrong, and this is not about that, never. And you are doing the best for your kids, and you try to find anyone in the other part of the world if necessary in order to improve it, and I feel really proud of it. So I thank you very much for your trust of my work. Okay, another question. Joe Breed. My daughter is almost 2 years. If her vision is not affected at the moment, because we have checked it every 6 months in London with Dr. Abu, when can we do first epicanthus and then the flap? Well, this is a very good question, because it's a regular case we have no pressure to do the doses, because it has a good vision, and we have to discuss. We can do the epicanthus first, and in some months ideally the doses, and we have, I think 2 years is time enough. We are doing trying to take rid the kids in order to have good appearance, or the more accurate appearance at the age of 5. Okay, so because at 5 is when bullying comes to the lives of the kids and suffering, and this is really a nasty thing. So, and we should avoid that. And if we can have a good result, and they can go through the childhood with little changes, but this is very good for them, and that's why this is my way of thinking. So before 5, and we have time to do it. From 2 years is perfectly well to do the epicanthus, and in the next months 6 to, or when we want the doses. But listen, in doses we try to do the surgery before the age of 4.5 to 5, in order to avoid psychological problems. This is a doses procedure. So, and if we have to take rid of the epicanthus first, we have to do the epicanthus first, and then the doses, but always before the age of 5. And if there is a lazy eye, as soon as possible. Muy Hongling. Dr. Medel, may I know if it is possible to operate the Strabismus surgery after Frontalis flap surgery? So we can do it, but it's not the ideal. So the ideal when we have strabismus and ptosis is first to take rid of the strabismus, and in the next months to take rid the ptosis. Why? Because the position of the eye, the position of the cornea and the globe is our point of is our point of control of the level of the ptosis. And if we have the eyelid looking down like this, we don't know where to set the eyelid in order to have a good appearance or good level. So we have to set the eye in position, the cornea in position, strabismus horizontal or vertical, and then we set the eyelid and the shape with the cornea and in position in order to have the best result. This is the ideal thing. But sometimes the squint surgeons ask us to do it first, and they adjust on the other way. But regularly, I prefer to do, and I think it's a consent to do the squint first than the ptosis. Also, how long after the frontalis flap surgery can we see the final result of the eyelid? So the eyelid will after the frontalis flap, we will have some swelling, some inflammation, and the eyelid will set in 2 or 3 months. We set down like 1 millimeter, we know, and they remain stable probably for long, a lot of years. And this is the time. But at the beginning, we have to recover the swelling, and also we can't forget about the auricularis muscle. The auricularis muscle is the muscle that closes the eyelid, and in those patients are really weak muscle, and we set the eyelids up, and this weak muscle has to make stronger, keep to be stronger in order to close, and it takes weeks to be stronger, to close properly, but it keeps improving for the whole life, because this, by regular blinking every moment, every day, this muscle is improving. So we have time to prove that, but it takes some weeks and some months in order to improve completely. Let's see some more questions. Mike Bessie. Our son is now 5 years old and needs his second sling surgery. Would you recommend any other procedure be done at the same time? So we never, when we do frontalis flap because it's better, and hardly ever we have to retouch, only a few cases. But we never change our mind when we do a resection of the levator resection, or we see a sling, we change to the frontalis flap because it's much better. But we never come back from frontalis flap to a resection or a sling, never. Because frontalis flap, when we want to retouch, is very easy, and we can redo as many times as we like, and we can, if we like, we can undo, and the muscle came back to the forehead, and the eyelid came down, and that's it. Nothing happens. So we have several advantages with the frontalis flap, but we never came back to the slings or the supramaxillary resection of the muscle. And it's a very nice technique. And I'm sure you have seen many cases, and I have operated patients that have been operated five times. So those are the things that makes me change my way of thinking and try to find a better thing. because I don't like when you do a surgery one time and you know from the beginning that you have to retouch. I don't know if 2 times, 3 times, 4 times. So this is not good medicine. I believe it. I don't like that. It can be a good result for any time, but it's not what I look for in medicine. I want to do as many procedures possible with the best result, and that's it. But if we do this surgery and we think that we know that we have to do it in 1 year or every year, that is the regular thing. So I don't like that. I prefer to operate cataracts, believe me. Cristina Coco Noya. Our daughter has been 4 years old, silicone sling in both eyes. One eye failed, recommending using her tendon from the leg for replacing the slings and bring the eyes closer with a mesh wire over the nasal upper. Well, there are several techniques, Christina. There are several techniques, but the same. I try to achieve the best goal with a less invasive procedure. And the slings, we know what it is, and I don't like, and we don't like, and that's why we do Frontalis flat, because it's better. And there are several ways to pass through the nose. One of the techniques that I was amazed watching the technique, because it's beautiful technique, was the transnasal wiring. And when I see Richard Cullen doing that, so I love it. I love it, and the results are really amazing. And it's passing through the nose a wire and duplicate the both canthal tendons in between them. But I think it's an aggressive surgery, and we can achieve almost the same or the same with less aggressive techniques that are better for your kids. And that's what if were my son, I'll try to do that. I don't know this technique about the mesh wire, because I guess it's a transnasal wire and from the nose. And I don't do that. I don't do that because I have very good results with the simplest things on the eyelids. But probably the doctor that recommends you has a lot of experience on that, and it's a good indication, I'm sure. Rocío Fernández Pérez. Rocío, ¿qué tal? ¿Es muy complicado para el paciente el posoperatorio? ¿Es doloroso? So she's asking, Rocío is asking about if the postoperative care or in Blefarofimosis syndrome is painful and is really hard operation. So, and I have to tell you, the two operations, the ptosis and epicanthus, we do it under general anesthesia, and we do also local anesthesia, because we want a painless surgery, and when we inject anesthesia on the place we are working, the anesthetist don't need to put painkillers on the vein of the kid, so the anesthesia is really superficial. It's not a deep anesthesia, and the superficial anesthesia, the kid gets up very quickly and without any complication, and it's very safe for them. So it's safer. So we do both. So el Rocío, hacemos la cirugía con dos anestesias, la general y la local. El hacerlo con anestesia local, la ventaja que tiene es que no es doloroso, y entonces el anestesista no tiene que inyectar en vena analgésicos, que es lo que más deprime en la anestesia a los niños. Con lo cual es una anestesia muy superficial y es una anestesia que realmente el niño se despierta y en 10 minutos o 5 minutos está con la mamá, ¿no? Y no tiene dolor porque además tiene anestesiado la zona de la cirugía. Y claro, esa zona anestesiada dura muchas horas y luego se mantiene con los analgésicos, normalmente con paracetamol y ibuprofeno, más que suficiente. As we inject local anesthesia, the zone remains numb for some hours, and then we keep remaining without pain or painless with the painkillers, with paracetamol or ibuprofen. Okay. Chigash. Our doctors here in Switzerland say a treatment should, if any, be done ideally when one is 18 and can fully agree also to the risk of the treatment. Wow. What's your opinion about that? So, if you have an appendicitis and you have to wait for to your son to have 18, so that has no sense for me. So the thing is that we should avoid problems to your kids, and the doctors are to avoid problems to your kids. And if you do this operation, you will have a psychological problem and unhappy person with 18 years old. So, in my opinion, if you have a congenital ptosis, you have to do it when it's better for the patient, not when it's better or safer for the surgeon. This is the way of thinking. So we are here to help, and we have to take rid of the problems of the kids. And if we don't do the ptosis procedure in any at the beginning, probably you will have lazy eye, and the doctor at 18 don't care about that. It's not his problem. It's your problem. It's the parents' problem, and your son problem. So, in my opinion, has no sense about that. Probably the person that you ask is not an expert on ptosis and is not an expert on BPES, which is a very very specialized problem, and we need a really expert to take rid of this problem. And this is my opinion. Assuming, so another question about is from Andrea Marinica. Assuming there are no vision problems, what is the oldest age to have the surgery? The year before dying. No. So I have to tell you that one of the most it's important when we have a good solution in kids and we give solution to kids because their life changes. But it's amazing when we operate an adult and his life changed dramatically, and they explain to us, my life has changed, and there are no time to do it. So you can do it whenever you like. I remember in Madrid I did an operation last month, 2 months ago probably, I don't remember, of a person 16 years old probably, with a congenital ptosis, bilateral, severe, and so has changed his face and probably his life. And so the only problem when you do ptosis correction, no Epicanthus, you cannot have this problem. But in ptosis correction, when we do it in adults, we have problems with the orbicularis muscle. Why? The same, because if we operate at 30 years old, person with a big severe ptosis, the muscle that close is really weak. No need to work to close because it's almost closed. So has 30 years of weakness. And when we set the eyelids in position, those patients used to have more corneal problems for lack of ophthalmos because of lack of closure. And it takes longer to recover the strength of the auricularis muscle, and the corneal problems take a little bit longer. But we use lubricants, and usually we don't have any problem with that. But those are problems if we do the surgery in adults or persons. We can do it. But there is no age to improve. Always we can improve. And we have to improve always. This is another question from Mike Vesey. For a child, what sequence of operation would you recommend? And are the best aesthetic results achieved when operating at the younger age or is in the teenage years? Very good question, Mike. I think I already answered my talk, but if I have to choose, I think it's more normal. It's better to tight horizontally first, so do epicanthus and telecanthus, and then ptosis. When we do all together, that we can do, and you show very nice results, and we have very nice results. One of the things that happen is that everything is too tight, because we tie the eyelid like this, so it's in tension, and with the eyelid up like this, so it's under tension. And at the beginning, there's a lot of tension, and it's more difficult to blink and all things. But if we can choose, it's better to do it in 2 times. But first horizontally, and then the ptosis. And I have to tell you another thing, because we work a lot on the middle canton, on the first surgery, but when we do the ptosis, we have the opportunity through the same incision to tie the lateral canthal tendon laterally, so to improve the aperture horizontally by working on the lateral aspect of the eyelid, and it looks very very good. So la pregunta es muy interesante porque nos pregunta sobre cuál es la secuencia de recomendación. En principio es lo que hemos hablado antes. Podemos hacerlo ptosis si tiene ambliopía, pero si no hay ambliopía, en mi opinión es mejor hacer primero el epicanto y tensar horizontalmente y el epicanto, y cuando eso está bien en su sitio, bien fijo, entonces tensar verticalmente para que pueda abrir bien. Pero es que además tiene una ventaja que estamos haciendo últimamente en nuestros pacientes, y es que durante la cirugía de la ptosis, a través del pliegue cutáneo, podemos trabajar en el canto lateral y ampliar, si queremos, la apertura palpebral horizontal en el procedimiento de la ptosis. Con lo cual tenemos una doble ventaja, una doble oportunidad de mejorar el aspecto del paciente. Muy interesante, Mike, esta pregunta. Vamos a ver alguna pregunta más. Irana López. Doctor, ¿cuándo es posible realizar la corrección del epicanto y de la ptosis en un solo tiempo? Hola Irana, ¿qué tal? ¿Cómo estás? Muy buena pregunta. No, en principio se puede intentar siempre, pero siempre tenemos que saber los pros y las contras. Es decir, Hay pacientes en que, por ejemplo, tienen un epicanto muy marcado o tiene una fimosis muy marcada, o sea, los párpados muy, muy cortos. En esos casos es mejor solucionar el tema horizontal antes y después la tosis. Hay pacientes que tienen muy poco marcado el epicanto, tienen poco epicanto o tienen una apertura razonable. En esos casos se puede hacer todo a la vez eh, y con buenas expectativas. Pero al final lo más importante es que el niño tenga un resultado muy bueno y tenemos que buscar siempre cuál es la situación mejor para cada paciente. Irana, this is a very nice question about from Irana Lopez. And Irana is asking us about uh, when is indicated to do the both procedure together, and it's very very important because any case is different, and if the phimosis, so the aperture horizontal, is really short and there's a big telecanthus, I prefer to take rid first of the epicanthus and telecanthus and then the doses. But this a mild epicanthus or mild telecanthus, and we can do it all together. And this is a good indication to do it together. But any case is different, and we have to evaluate every case. And of course, we have to evaluate if the vision is fair, and the vision is fine, and there is no no lazy eye, and we have to individualize every case. So Kelly, you asked so many questions. I have 20 here. So, I don't know what to ask. Anali Barreto. Buenas tardes, Ramón. Desde Asunción, Paraguay. Un gustazo. No es una pregunta. Un gustazo escuchar tus clases. Saludos, Anali. Carolina Muñoz Fernández. Doctor. Lucía y yo le saludamos desde Burdeos, Francia. Operaste a Lucía y fue la mejor decisión de nuestras vidas. ¿Cómo conseguiste esa perfección entre los dos ojos? Jolín, Carolina, gracias por tus palabras. Yo siempre intento hacerlo mejor y a veces sale, ¿no? Tenemos suerte. Otra pregunta. ¿Cómo conseguiste agrandar la apertura del ojo? En el caso de Lucía, la apertura es magnífica y creo que trabajó las 4 esquinas del ojo. Gracias. Bueno, Carolina, es verdad. Cada caso es diferente. Hay casos que solamente trabajando en el epicanto tenemos una apertura muy parecida a la del adulto o muy parecida a la normal, con lo cual es suficiente, pero hay pacientes que no. Y lo que sí hemos visto, una de las cosas que sí que hemos visto en cada paciente, que yo no sé si está descrito, porque se habla mucho de la laxitud del tendón cantal medial, pero no se habla de la laxitud lateral, y hay laxitud lateral. Entonces, podemos trabajar la laxitud medial, podemos trabajar la laxitud lateral y podemos trabajar la tosis. Y bueno, y cada caso es diferente. En tu caso, yo recuerdo perfectamente a tu hija, porque además tenía alguna cicatriz que nos dificultó un poquito el manejo. Por eso, cuando hay cicatrices previas en los párpados, un párpado es una estructura móvil. El párpado superior es muy móvil. Si tú tienes muchas cicatrices en el canto medial por el epicanto, la cicatriz es una estructura rígida y no permite un buen funcionamiento del párpado, un funcionamiento natural de los párpados, ¿no? Entonces, tenemos que trabajar mucho sobre las cicatrices para que ese párpado sea más móvil. No es sencillo, evidentemente, pero bueno, en el fondo hay que, como siempre, individualizar cada caso. Yo creo, ¿cómo estamos de tiempo? 23, yo creo que llevamos una hora. ¿Alguna pregunta más? Que no haya respondido. Yo creo que están todas bastante contestadas. Una pregunta muy directa de IS. ¿A qué edad se puede operar el epicanto? Es una pregunta tan buena que yo no sé la respuesta. Se puede operar, depende. Lo podemos operar pronto, pero también cuanto más pronto lo operamos, menos desarrolladas están las estructuras de la cabeza, de la órbita, y más impredecible es el resultado. Con lo cual, es una muy buena pregunta y hay que operarlo lo suficientemente pronto para que ayude y podamos hacer la tosis no demasiado tarde, pero no demasiado pronto para que el resultado sea longevo en el tiempo. Cuanto más pequeño es un niño, menos predecible en el tiempo es el resultado. Entonces, operar el epicanto al año de edad, 2 años de edad, es perfectamente correcto. Operarlo con pocos meses, solamente si es necesario. Con lo cual yo creo que es importante. Veo aquí varias preguntas que hablan del coste de la operación. Y os tengo que decir que no lo sé. Que depende el sitio donde operéis a vuestros hijos, será de una forma o será de otra. Hay clínicas que los costes son más caros, el IMO es una clínica donde los costes son elevados, pero hay asociaciones y operamos en otros sitios que el coste no es tan elevado. Pero preguntar en los grupos, yo creo que hay muchos pacientes que se han operado y podéis informaros de los costes con ellos. Y si queréis operaros en IMO, pues llamar a IMO y os informarán de todos. Realmente no lo sé. Y si no, pues en los grupos de tosis congénita, yo creo que tienen toda la información. Sobre todo la asociación de tosis palpebral, internacional de tosis palpebral, que hemos operado muchos niños ya con ellos y os pueden ayudar a tener un coste mejor para estas cirugías. Bueno, yo creo que casi estamos, ¿no? Llevamos 1 hora y 10 minutos y bueno, agradeceros con mucho por las preguntas que habéis mandado, por vuestro interés. Ha habido un interés muy importante y realmente es un tema muy peculiar porque es un tema muy enfocado. Pero creo que es importante que se dé luz a estos temas, que aunque sean con menos frecuencia que la tosis congénita o que otras patologías, que la blefaroplastia o que los tumores o que la orbitopatía, es muy importante que sepáis qué es lo que estamos haciendo y cuáles son los beneficios de lo que estamos haciendo y que son cosas muy especializadas. Yo creo que I'm very happy for your for staying with us this hour speaking about Blefarofimosis and your trust in our work. And we have like 300 attendants during this hour, which is for me is a very high success because it's a very focused theme, focused topic, and a very particular topic. And but I love a lot these patients because we improve and we help to improve the life of those patients, and I'm really proud of having your trust. And I really appreciate all your questions that you have sent during the session and the ones that you have sent it before to our YouTube channel. And thank you for being here. I'm happy if you can share it and you can subscribe yourself to the YouTube channel, and we keep going and showing things that we are doing and in order to improve the knowledge and the information about these topics. Thank you very much.